Welcome to today's lecture on de-escalation techniques. Our primary goal is to resolve a patient's issues, especially when it revolves around anger or violence. We want to use a non-violent way to help maintain that safe environment. In most facilities, you'll see that they'll use a type of non-violent crisis intervention model. When we look at signs and symptoms that might be predictive factors of a outcome becoming violent. We have to look at signs and symptoms, but also pre things that precede that. So they could have an angry, irritable behavior. They can be hyperactive and engaging in pacing, restlessness, slamming of doors. We have to look at their anxiety levels, look at what their body is putting outward. Are they having tension, clenched jaws? Do they have a fist, a rigid stature? Are they mumbling to themselves? Are they short of breath and sweating or having increased heart rate? Are they verbally abusive, using profanity and being very argumentative? Is their voice loud? Is there a change of pitch? Or if there's a very soft voice that forces people to strain to hear. What about their eye contact? Is it intense? Or are they engaging in eye contact avoidance? If they've had recent acts of violence, especially towards property, if they have a stony silence, suspiciousness or paranoid thinking, alcohol or drug intoxication, maybe they possessed a weapon or object that may have been used as a weapon, either currently or maybe they came in that way. And then look at your milieu characteristics that can be conducive to violence, like creating that, or maybe collectively you're realizing something is going on, is drawing your attention. So maybe there's a loud environment, if it's overcrowded. If you have inexperienced staff, if you have staff members who are provocative or controlling or inconsistent, or if there's poor limit setting, then this milieu characteristic can promote that type of violence or can create aggression. Other things like screaming, cursing, yelling, throwing objects, hitting, and punching self or others are signs as well. Your goal for de-escalation is not to further provoke the patient who's already in a state of agitation. You want to provide them a space and time to calm down, because this empowers the patient to use their own coping strategies, whether it be the ones they came in with or the ones that you've been helping them develop. And then using communication that is really calm and reasonable and non-threatening in their tone is going to be helpful. Where patients are in contact with their family, and with the consent of the patient as well, it is good practice to try to involve them in helping with not only evaluation but also the treatment plan, especially if the patient comes in already angry and aggressive in a crisis state. Ask the patient and family what has been helpful in the past when that person is upset and agitated. Educate the family on the reason not only for the admission to the hospital, but what to expect during that stay. And then let the family remain with them if it is a safe space with the patient, and to help give them that comforting and support, because that's part of their support system. And then make sure that the family, again, is part of their treatment after admission to the discharge. And again, a little bit of that has to do with making sure that you're talking with the patient first and making sure that it's okay to continue to use their family as a support system. And as long as it's a safe environment, we can include them. Other de-escalation techniques include using distraction, active listening, sensory modulation, and integration activities. With sensory modulation and integration activities, we're using grounding physical activities like holding a weighted blanket, arm massages when appropriate and not overdoing it, aerobic exercises, or using sour and fireball candies. With your calm, soothing activities that are included in that sensory modulation, you can encourage them to use hot shower baths, drumming, use decaffeinated tea, rocking in a rocking chair, using beanbag tapping, yoga, wrapping them again in a heavy quilt. Some areas may have a comfort room or like a sanctuary that provides safe expressions of feelings within boundaries. Reminders are to make sure that you involve the patient in that decision-making process. Remember that physical holds, seclusion, or restraints are a last resort into preventing them from being a harm to themselves and others. PRN medications can be used, or regularly scheduled medications can assist them, including anti-anxiety medications like lorazepam or diphenhydramine or Benadryl. And then you have your mood stabilizers like lithium, carbamazepine, valproic acid, beta adrenergic blockers like propranolol, metoprolol, antipsychotics. And this is more for your patients who have psychosis and mania. Just remember that there are some side effects that come along with these medications, including acute muscle spasms and irreversible tardive dyskinesia. Just remember, I want to go back a little bit. When you're thinking about these medications, I want you throughout your courses to think, what is this medication? How does it take its action? And then what is the expected outcome? So if you have a patient who's very anxious, what's going on? Their heart rate's up, their respiration's up. They are excitatory. So you want to give them medications that are going to inhibit that excitatory portion of them. And that's where you see propranolol and metoprolol and things like that. So just kind of start making those connections with those medications. Treatment outcomes is to help them to regain control over their aggression and their thoughts or feelings, to decrease any psychomotor activity that says that they have signs that they're aggressive. You want them to have a relaxed posture, unpressured speech, and be able to speak with you directly without anger, to be able to express what their needs are. You want to engage in de-escalation so that you can require less sedation medications. You want to increase their toleration for frustration. A lot of times when individuals are frustrated, they immediately look towards just expressing themselves. But sometimes if you can help building them that resilience that says we don't always have to respond when we're frustrated, that we can remove ourselves from a situation and then give them the ability to have alternatives to what they can do versus putting up with behavior. And then help them to be more effective with using coping strategies. Self-awareness issues you want to keep in mind. Watch your body language. Make sure that it's non-threatening. Respect the person's space and their boundaries. Be aware of the surroundings, making sure that the patient is not in between you and that door. Making sure that if you're in your office, let other people know where you are so that they can come and find you, maybe relieve you, check on you, and then remove items that can be of harm, especially from your own person. That includes scarves, necklaces, dangling earrings, and cell phones. Crisis prevention interventions like CPI has been used to train professionals on how to de-escalate patients. Some of the tips that they have include being empathetic and non-judgmental. These help you really respond to difficult behavior in the most safest possible way. So being empathetic and non-judgmental. So when someone says or does something that you perceive as weird or irrational, do not judge or discount their feelings, whether or not you think these feelings are justified. They're real to that person. So pay attention to them. Keep in mind that whatever they are doing, that they're going through, it may be the most important thing for them right now in that moment. The next tip is to respect personal space. If possible, stand 1.5 to 3 feet away from a person who is escalating. Allow for that personal space to decrease their anxiety, and then you can help them help be a part of that prevention of them acting out. Tip 3 is use non-threatening nonverbals. The more a person loses control, the less they hear your words, and the more they react to your nonverbal cues. It just doesn't. It just, if it's not appropriate, it won't help. So make sure that your verbal cues are non-threatening. Use non-threatening nonverbals. Be mindful of your gestures, your facial expressions, your movements, and tone of voice. Keeping your tone and body language neutral will go a long way towards diffusing a situation. Avoid overreacting. Remain calm, rational, and professional. Remember to control that you can't control the other person, but who you can control is you. You can't control how they respond. So be positive, um, or be positive in your own thoughts that tells you that you can handle this and that you know what to do, and it helps you maintain your rationality, and it also helps to calm that patient down. If you overreact, it only adds to the situation. Focus on feelings. Facts are really important, not only to you but also to your patient. It's about how a person feels is basically at the root or heart of what's going on. Yet some people have trouble really identifying and how they feel about what's happening to them. So you want to watch, you want to listen carefully to what that person is saying. Listen to the message they're trying to portray. Try saying something like, "That must be scary." Supportive words like these will really help that person know that you understand what's happening and allow you to be able to give a positive response. And that's really the basis of being empathetic. Ignore challenging questions. Answering challenging questions often result in power struggle. When a person is already challenging your authority, you have to really redirect their attention to what's really going on at hand. Ignore the challenge but not the person. Bring that focus back to how you can work together to solve a problem. Set limits. If a person's behavior is really belligerent, defensive, or disruptive, make sure that you're giving them simple, clear, but reasonable choices. Let them know what their consequences are and make sure that it's enforceable. A person who's upset may not be able to focus on everything you say. So make sure, again, be clear, speak simply, and offer positive choices first. Choose wisely what you insist. Now, it's important that you be thoughtful in deciding what rules you're going to enforce and which ones you won't. If a person doesn't want to shower in the morning, is it possible to let them do it at another time that feels best for them? If you can offer them an option and offer them flexibility, you may be able to avoid any unnecessary altercations. Allow silence for reflection. We can all benefit from a little bit of silence, even though we may feel as though it's awkward. While it seems counterintuitive to let moments of silence occur, it is probably the best choice when you're dealing with a situation where you're de-escalating. It can give a person really a chance to reflect on what's happening and how he or she needs to proceed. Believe it or not, silence can be a powerful communication tool for not only yourself but also for the patient. Allow for time for them to make those decisions. When you have someone that's upset, they're really not thinking clearly. So give them a moment to think. You pressuring them to try to think doesn't help the situation, and a person's stress can rise when they feel like they're being rushed. So allow them time to think, and that allows them time to calm. And this brings us to the end of this lecture.